turn it over to our first part of our program, which is a panel on imaging and treatment modalities for skin cancer, from total skin to millimeter targets. And that will be moderated by Rob Cormack, who really needs no introduction to this group. So Rob, all yours.
Thanks, Bear. It's a pleasure to be here. Just a couple bookkeeping items before we get started with the presentations. We're going to hold off questions until the end. So if you have questions, feel free to use the chat as a notepad so you don't forget your questions, but we will not be interrupting the presentations to address those. Speakers planned for 20 minutes. I'll give you a warning at about 3 minutes. Other than that, I'll be quiet. And I think at this point, we will send it off to the first presentation, which I believe is pre-recorded, correct? So so we'll start off with Dr. Rajadhyaksha, who I have clearly butchered, and we'll go into a presentation on imaging for skin cancer. Thank you.
Thank you very much, Ileana, for asking me to participate in your meeting and to speak in this session. Hello, everyone. A very good morning to all of you from New York City, from Memorial Sloan Kettering Cancer Center. I'm going to speak to you about optical microscopic imaging for guiding diagnosis and treatment of basal cell carcinomas in skin. And in particular, I'm going to talk about the evolving role of reflectance confocal microscopy combined with optical coherence tomography to potentially guide Mohs surgery. For a number of years now, we've been developing these optical imaging approaches for the preoperative imaging and detection of margins on patients in vivo. This is before the start of surgery, followed by the intraoperative and postoperative imaging to look for the presence or clearance of any residual tumors. And following years and years of device development work and benchtop studies, we have recently progressed to testing these approaches on patients. So I'll talk about recent progress in implementing these imaging approaches in a couple of our Mohs surgery settings. I'll also talk about our progress in using optical imaging approaches to guide laser ablation of basal cell carcinomas. And I'll touch very briefly upon the latest bit of work, which is the possible use of imaging, reflectance confocal microscopy, and optical coherence tomography to potentially guide brachytherapy. Now, before I go on any further, it's time for my daily confession. A couple of my microscopes have been commercialized by Caliber Imaging and Diagnostics. Perhaps some of you may have heard of these microscopes. They're called vigoscopes for imaging skin. A long time ago, after leaving MGH and before joining Memorial, I spent a few years working in the company. Back then, we were a small startup company. I now happen to hold a small amount of equity. Mohs surgery, as many of you, perhaps all of you in this audience may be quite well aware, is a standard approach for the treatment and excision of basal cell carcinomas, particularly the aggressive, the high risk, the deeper subtypes. Mohs surgery offers very high cure rates, and that's because Mohs surgery is guided by the preparation and the examination of frozen pathology to look for the presence or clearance of any residual tumors. So frozen sections are prepared while the surgery is in progress, and the Mohs surgeon reads the pathology at the bedside in real time in parallel with the progress of the surgical procedure. So the feedback happens while surgery is in progress. So as you can imagine, this is an amazingly efficient approach for completely clearing tumors of the patient. But it does take time to prepare frozen sections. Depending on the setting, it can take anywhere from 10, 15 minutes up to even an hour for each excision to be processed, with the result that the overall procedure then becomes slow, it becomes inefficient, particularly from the patient's perspectives, because patients have to wait, simply wait between each excision while frozen pathology is being prepared. So this is where we think non-invasive optical imaging approaches may be useful and may add some value. So with reflectance confocal microscopy, RCM, combined with optical coherence tomography, OCT imaging, one can preoperatively map out tumor margins on patients in vivo And then while the surgery is in progress, one can intraoperatively or postoperatively look for the presence or clearance of any residual tumors directly in excised wounds on patients in situ. So large areas of tissue may be quickly examined at the bedside, and the imaging may then serve as very useful adjunct for pathology. With a confocal microscope, one can perform what is known as optical sectioning instead of physical sectioning that we do with biopsies. So one can non-invasively image thin optical sections in living tissue. One can image individual layers of cells, and we image with high resolution, which shows the nuclear and cellular morphology, patterns of cells, patterns of nuclei in normal skin, as well as in basal cell carcinomas, as well as all other types of skin conditions. We acquire mosaics that help to extend the field of view and display larger areas of tissue, which is necessary for surgeons and for dermatologists, for clinicians, and for pathologists. And in this particular mosaic, you can see this darkish grayish nest of tumors that I'm pointing to. I hope you can see my mouse, my cursor. These turn out to be, these are nodules of basal cell carcinoma. This is a nodular type of basal cell carcinoma that I'm showing you. Our mosaics can display up to 8 millimeters by 8 millimeters field of view. And in this particular mosaic, you're seeing literally chock full of these tumor nests, these nodules, and these appear as darkish, grayish, hyperreflective nests. If you look closely, you see tumors in the form of dark basaloid nests with these clefting patterns, these optically dark spaces, and palisading patterns. There are patterns of cells along the edges of these tumors. And if you zoom in and look more closely at these patterns, you'll see nuclear morphology in the form of elongated nuclei, monomorphic nuclei, nuclei that are polarized, meaning they're all oriented in one particular direction. With OCT imaging, one can also perform optical sectioning, albeit now we trade resolution for depth. So one can image deeper, and what one can see are the different layers that make up skin, such as the epidermis, labeled E here, the dermis, the junction between the epidermis and the dermis, the dermal epidermal junction, as well as in real-time imaging, we can see some of the deeper underlying vasculature and blood flow. And basal cell carcinomas also appear as these darkish grayish nests of tumors right below the basal layer in the dermis, albeit now you see these with lower resolution. Both RCM imaging and OCT imaging provide about 80–90% sensitivity and about 60–70% specificity. With RCM imaging, we have the resolution to look at cellular level morphology, but the imaging is relatively slow and we don't image too deep. On the other hand, with OCT imaging, one can image deeper, one can image faster, but the resolution allows us to look at only the different layers that make up skin. But these are highly complementary capabilities. And so it was really a no-brainer for us to think about combining the two into a single device. And that's exactly what we did in partnership with my good friends and colleagues, Niku Sorifthemia at Physical Sciences Incorporated, PSI Incorporated, and Bill Fox at Caliber Imaging and Diagnostics, and my group at Memorial. So this work was led by Nick Isthemia, and we put together a couple of these handheld prototype devices. Both of these now are in the hands of my Mohs surgeon colleagues who are using them, who are using the devices in their Mohs surgery settings. I'll show an example. This shows you a superficial nodular type of basal cell carcinoma. And with reflectance confocal microscopy with RCM imaging, one can detect and diagnose the presence of these tumors. With orthogonal OCT imaging, one can get a sense for the deep margins and the depth. And with on-fast OCT imaging, one gets a sense for the lateral margins and the lateral spread. And in this device, we very nicely registered the RCM field of view within the larger OCT field of view. And in a couple of initial studies, a number of my Mohs surgeon colleagues, dermatologists, and a dermatopathologist showed that they can read such combined RCM OCT images with very high sensitivity and about 75% specificity. More importantly, with OCT imaging, we now have a much better sense for the depth and the deeper margins of these tumors. So with RCM imaging, the imaging helps guide diagnosis, And with OCT imaging, we can measure the depth of these tumors. So OCT imaging helps triage these lesions, these BCC lesions, into those that are shallow and can be treated with non-surgical approaches such as laser ablation or topical therapy or brachytherapy, versus those lesions that appear to be deeper and must be treated with more surgery or with surgical excision. So RCM imaging combined with OCT imaging now helps guide both diagnosis as well as treatment. At Memorial, we are fortunate to have 5 Mohs surgeons in our dermatology service, of whom 3 of them work very closely with us with our imaging work. So a couple of my Mohs surgeon colleagues, Dr. Anthony Rossi and Dr. Kishwar Nahal, have been using our devices. This is for imaging of tumor margins, of BCC margins on patients before the start of surgery. And they've been implementing and testing this imaging approach. The question is, how might RCM OCT imaging help address patient and Mohs surgeon concerns? And by the way, these are standard concerns that almost every patient asks about. Are there any tumors left after the initial diagnostic biopsy? What are the subtypes? How deep and how spread out might they be? How many stages or excisions may be required? And what type of repair or reconstruction may be needed? So I'll show an example case. This is of a nodular basal cell carcinoma. In this case, there was no clinical evidence of tumor after the initial diagnostic biopsy, but RCM imaging was able to detect the presence as well as help determine lateral margins. And with OCT imaging, one could detect the depth and the deeper margins. More recently, we are finding out that with OCT imaging, one can begin to detect some of the deeper infiltrative and micronodular types of basal cell carcinomas. And so this now begins to highlight the true synergistic value, the true added value for combining OCT imaging with RCM imaging. More recently, my colleagues, my Mohs surgeon colleagues, have progressed to using imaging for the management of complex BCCs in the head and neck areas. This is now imaging and decisions all being made in real time at the bedside. In other words, imaging to help guide surgical planning. What are complex basal cell carcinomas? These are typically tumors that recur in the head and neck areas. They present with multiple recurrences. They consist of the high-risk subtypes. They tend to be large. And because of that, they require large excisions with complex reconstructions. Turns out the imaging can help detect detect the presence of residual BCCs and help detect deeper margins. And so on a number of patients, the imaging helped the Mohs surgeons determine a priori the number of excisions or the number of stages that would be required. In other patients, the imaging helped detect the spread of lateral margins well beyond the obvious visible surgical margins. And so on 3 patients, this led to a change in surgical planning. And on a couple of other patients, the imaging showed the lesions to be quite shallow enough that the Mohs surgeons were able to avoid surgery altogether and avoid complex reconstruction. And instead, they could treat such lesions on patients with non-invasive topical therapy. And this is important because, in many situations, the patients who come are quite elderly. They tend to be in their 70s, 80s, 90s, 100s. And so one can avoid surgery altogether. And if the imaging can help avoid surgery, that in fact is of great benefit to the patients. In other news, we've also made progress in the use of reflectance confocal microscopy to potentially guide laser ablation of basal cell carcinomas. And again, following years and years of benchtop studies, I'll talk about recent progress in the clinic. Now, compared to most surgery or compared to surgical excision, laser ablation is much less invasive. One can literally vaporize tissue cell layer by cell layer. And ablation is particularly well suited for superficial and early nodular type of basal cell carcinomas, which are shallow and don't go too deep. But the challenge is that all of the tissue is vaporized. And so there's none left for pathology to look for the presence or confirm for clearance of any residual tumors. One of our most surgeons, and this is now the third most surgeon who works with us, Dr. Chishan Jason Chen, uses an erbium YAG laser quite routinely on patients for the ablation of these type of basal cell carcinomas. And so we've been working with Dr. Chen to determine whether after ablation, one can directly image for the presence or clearance of any residual tumors on patients. But to combine imaging with laser ablation, there's a catch. There's always a catch, right, in the research business, which is what keeps our life interesting and exciting. It turns out that ablation, even if you perform very carefully cold laser ablation, can still leave behind a thin zone of thermal coagulation that can be typically tens of microns, or it can be controlled to within a few microns. And so the question for us was, can we optimize our laser ablation parameters so that we can very carefully perform cold ablation and very carefully control coagulation, so as to then preserve tissue viability, which would then allow us to label nuclear morphology with some contrast agent, which would then ultimately allow us to do imaging and look for the presence or clearance of any residual tumors. Turns out the answer is yes, based on a number of benchtop studies. And to make a long story short, as you might imagine, one has to limit the fluence in each pass and limit the number of passes. And between passes, we allow for the tissue to be cooled, either passively or actively. So following the benchtop studies and a bit of initial testing on patients, Dr. Chen decided to proceed to testing this approach on a number of small lesions on the backs of a small number of patients. So this is imaging to detect the presence of basal cell carcinomas, followed by imaging to map out margins, followed by ablation, followed by imaging to confirm clearance, and then more imaging at follow-up, with no pathology being prepared at any step in this process. And so far, he has tested this approach on 47 small lesions on the backs of a small number of patients. We acquired mosaics that helps determine the lateral spread of these tumors. We acquired stacks to determine the depth and the deeper margins. And we acquired stacks in each quadrant so that we can then tune our laser ablation parameters depending on the depth in different quadrants. Now, all of this work was before we had built our RCM OCT device. Today, of course, now of course, we use our OCT imaging approach to look for the depth of these tumors. After ablation, we acquire videos and perform video mosaicing to look for the presence or clearance of any residual tumors. And these are small lesions, so we can quickly cover the complete area with our video mosaicing approach. We use aluminum chloride as a contrast agent, which labels nuclear morphology and makes nuclear patterns appear bright with a strong contrast. We can detect the presence of tumors that may be there after ablation, such as what you see here. We can detect the clearance of these tumors when all of these tumors have been cleared. And the results so far are quite promising. On 44 of these lesions, Dr. Chen is seeing complete clearance and no recurrence with mean follow-up out to 40 months. Many of these lesions have been followed up out to 60 months or 5 years, which, as some of you may know, is a major milestone or a benchmark when looking for the recurrence of basal cell carcinomas after treatment, to look for treatment efficacy. We noticed 2 recurrences and 1 case of hyperscarring. Similar studies are in progress with a carbon dioxide laser, which is preferred by Dr. Anthony Rossi. And he's seeing similarly good results in 22 small lesions, all clear, no recurrences, with mean follow-up out to 28.5 months. Many of these lesions have now been followed up and monitored out to almost 3 years. Finally, I'll talk very quickly about the latest bit of work, which is the possible use of imaging to guide brachytherapy. In other words, the response of basal cell carcinomas to brachytherapy as imaged with reflectance confocal microscopy. And this work is being led by Dr. Chris Barker, who is a radiation oncologist in our group. I'll skip all of the details except to say that so far Dr. Barker has tested this approach on 12 patients, lesions located in the head and neck areas, looking at all subtypes of basal cell carcinomas. He looked at previously described features of basal cell carcinomas, as well as managed to observe and look at some new features which appear to be specific to radiation treatment. So here's an example of a micronodular basal cell carcinoma on the forehead. At baseline, we see the presence of tumors with clustering and palisading patterns. 6 weeks after treatment, we see these bright nucleated dendritic cells in the epidermis with tumor that's beginning to fade. These we think are Langerhans cells. 3 months later, we see an atypical honeycomb pattern, which suggests epidermal atypia due to radiation. And then about a year later, we see the onset of fibrosis and amorphous collagen. Some of the features appear to be specific to radiation therapy or to brachytherapy, such as radiation-associated epidermal atypia, the presence of these large bright cells. We don't quite know what they are just yet. We see a lot of fibrosis, perifollicular fibrosis, and we see epidermal dendritic cells. So again, tumor features at baseline. Inflammatory features are seen around 3 months, and then fibrotic features are seen at 12 months after the treatment. So far, Dr. Barker has seen no clinical or dermoscopic signs of recurrence, and so no biopsies have been performed with many of these lesions, with mean follow-up out to 31.7 months, and many of these having now been followed up out to almost 4 years. So it's interesting to think about the possibility that someday reflectance confocal microscopy combined with OCT imaging may help non-invasively guide diagnosis, followed by determination of margins, all of this directly on the patient, followed by treatment, either Mohs surgery or some other non-surgical approach, followed by the detection of the presence or clearance of any residual tumors. Again, all of this on the patient, and all of this may happen at the bedside in a single visit. The so-called one-stop shop patient care paradigm that many of my colleagues are now beginning to call this approach. And such imaging approaches may then serve as very useful adjuncts to pathology. Now, I said someday this may happen, but this is happening already in the hands of a few of my Mohs surgeon colleagues, as well as a few other colleagues in Europe, particularly in Spain and in Italy. In our setting so far, RCM OCT imaging has helped detect and diagnose the presence of 151 BCCs, as well as the imaging has helped triage these lesions for treatment. And this has been in 91 patients over the last 5 years. As you can see from this flow chart, some of these lesions have been treated with laser ablation, some with Mohs surgery, some have been removed with shaved excisions, and other lesions have not been treated and are simply being monitored. And this is key. 20%, almost 20% of the lesions are being simply watched and not being treated. So the imaging can lead to more efficient approaches for the diagnosis and the management of these type of skin lesions. So with that, I will say my thanks to Memorial for providing me with the seed capital many, many years ago to establish my optical imaging lab and program. And now, of course, my thanks to the NCI, the NIBIB, and the NIDCR for being tremendously supportive of all of the work. And since all of my funding now comes from the NIH, I thank you all for your support and for your money. Thank you very much.
Okay, thank you. I think at this point, we're going to move on from the very small to the very large. And I'd like to welcome Dr. Tu, the chair of radiation oncology at Beth Israel-Lahey, who will be discussing total skin electron beam irradiation.
Do we have Dr. Su online yet? I was just texting him to see if he's been able to join us. So Rob, I'm not sure if it would be okay to go a little bit out of sequence, but if we...
Stefan, are you available?
Absolutely, yes.
Excellent. So what I'd like to do now, while we work out some technical issues, I'd like to welcome Dr. Buzurovic from the Brigham and Women's Hospital, who will be talking today about some advanced treatment planning techniques, specifically for brachytherapy. So we started out very small. We were going to go very large, but now we're going to be somewhere in the middle.
Thank you both.
Thank you, Robert, for your introduction. I hope everybody can hear me well and see my screen. as Robert mentioned, I'm going to talk about advanced treatment planning technique, and I'm going to limit the talk to the HDR surface brachytherapy. So the strategy for going for a small to large is actually going to be fulfilled, because we are actually here going to talk about complicated targets with a complicated topology. Initially, I'm going to spend 1 or 2 slides talking about motivation, and I'm going to present our volume and to see what was the reason for us to start thinking about advanced treatment planning technique versus a standard treatment technique that we actually develop and we talk about at a major meeting, at a workshop, etc. We are going to talk about only in 1 slide what is our long-term goal in a skin brachytherapy, and where do we think that this field will go in the near future, or at least where we are going to bring our clinic in the future. After that, I will talk about several things related to the automated catheter digitization. I'm going to show very quick treatment planning using the CT and MRI. I will talk about automated treatment planning using the CT and MRI modalities. We will present here also our vision of a 3D printing in skin brachytherapy, and at the end of this talk, I will talk about the role of MRI imaging in the surface brachytherapy. During this presentation, I will present already published material that we published during 2020 and 2021 on these topics, or some material that are in the process of publishing. So basically, in our clinic, we are reaching 400 patients that receive various types of brachytherapy, and those patients receive up to 1,500, and this year we are reaching to a number of 1,500 fractions of brachytherapy. Therefore, our skin clinic is busy as well. We are about 40% of our skin brachytherapy, about all delivered fractions belong to skin brachytherapy. It is about 413 on average in the previous 10 years. In the previous 4 or 5 years, it comes to the 480%. And the important part for this is that 75% of all our fractions or treatment plans are complex. When I say complex, I mean that we use 20 catheters or more to generate a treatment plan and to deliver the treatments successfully to our patients. Therefore, we had to do something about that. We had to think about what are the additional patients' benefit that we can bring in such a busy environment, and in addition to that, how we can additionally use and optimize hospital resources. When we published the APM task group, we participated in the APM task group on surface brachytherapy. We developed the standard workflow, which contains 3 principal processes: simulation, treatment planning, and treatment delivery. In this talk, I will talk about the treatment planning only, and additional principles that are related to improvement of the treatment planning process. I'm going to show only 1 slide on conventional treatment planning. So we do not need to contour the skin. We contour the markers that physician place around the target, and that's sufficient to define clinical target volumes. It's a standard that the 100% wise dose line dose should be delivered 3 millimeters under the skin to reach the dermis, and the overall recommendation is to keep 125 isodose line under the skin. We can go deeper with HDR brachytherapy to reach the plaque, if any. In that case, you would have non-uniform depth. However, is 3 millimeter clinical standard? No current reports will not say always that's a recommendation, but not standard. We want to, in our future research, when I talk about MRI, we will talk a little bit about treatment depth and our vision and our approach to that problem. I am not going to show the cases, but a series of cases, but I will show one case to see what we are dealing with on a regular basis. So this patient was diagnosed with a CTCL. We generate on a whole face. We generated plan using a face mask. We used 66 catheters. We had about 700 valve positions with the medium hot source or medium cold source, however you want it. The source out time was about 37 minutes. In total, it was about hour, maybe hour and a half, because we had to use 2 transitions for a treatment, because our afterloader can have up to 30 catheters at the same time. This is actually the simulation process. You can see the 4 applicators attached to the face mask. These are the digitized catheters, and this is actually the most beautiful radiation. This is the most beautiful radiation dose distribution in radiation therapy. You can see yellow isodose line is 3 millimeter under the skin, equidistantly, completely over the whole target. So this is what we are dealing. Can we improve this? This is another patient I think Dr. Devlin is going to show, but this is actually a patient that we treated post-resection, diagnosed with angiosarcoma. Similar situation, a little bit cleaner and a little bit better face mask because the target was smaller and not didn't have such a complicated topology. And after that, we actually wanted to express our research goal. To strategize and to develop this treatment planning, it takes days. Our idea is, can we treat this and can we generate a treatment plan, not in hours, in a second? That's our goal. Actually, if we have to put that in a proper wording, in a scheduling terminology, can we schedule, sim and treat patients for a complex HDR brachytherapy? So patient does not need to come several times, wait for a few days to generate a complicated mold or complicated treatment apparatus. Can we sim the patient and treat immediately? We are thinking about using non-ionizing radiation for imaging, and I will talk a little bit about that. And we are thinking utilizing and doing MRI only treatment planning, with the reason that will be clarified in the future. So now I will briefly talk about several projects, and first one is automatic catheter digitization. Actually, we realized that if this is actually workflow that we developed for a purpose of task group 253. We realized based on our study, if we can only digitize the catheters automatically, we would be able to save several months or actually whole month of a physics effort over the year in a clinical setup like ours. So you can imagine to digitize the catheters, meaning dropping all those points 1 centimeter apart over such a large surfaces, it takes literally forever. So this is actually our vision. I'm sorry. This is actually our vision, and this is an in-house developed software that will result in digitization of the identifying the applicator on the patient's skin in just a few seconds versus a few hours in a regular clinical setup. So what is necessary in this solution is contouring is not necessary, and the specific digitization of each individual dwell points of a marker inside the catheter is not necessary. Only what is required is to drop the anchor points on the 2 slices, and the anchor points in the 2 slices would be connected and the catheter would be identified in each slide. This is how it should go. So just the dropping anchoring point. Software is automatically adjusting to the catheter positions. And this is a 3D representation of an image stack. And in this case, anchor points dropped on 3 slices. And this is actually just a simple generation software. We continue and generate the applicator. As a result, we have a file that contains numerical values of a position of applicator on and that file can be imported into the conventional treatment planning system. So what is the further idea? If we have applicators registered properly, can we eliminate the whole standard treatment planning process? The answer is absolutely yes. Once when we have a position of the applicator, what we want to do, if we understand the fiber flap applicator, it contains the spheres of 1 centimeter diameter. So the surface to the skin distance is 5 millimeters. Additional 3 millimeters is a depth of 3 millimeters under the skin. So now we are looking at the problem which can be formulated as, can we calculate the dwell times on a known applicators or on a known catheters in order to have dose of 100 prescription dose or 100% of the dose at 8 millimeters away from the shell where the all dwell times are. And as a result, this is an automated treatment plan. So basically, we were able to cut just several hours of work to several seconds in using a CT. Second way how we see that automated planning can happen is to define so-called applicators library. People are familiar in HDR brachytherapy with the library of intracavitary applicators, and those libraries are used to improve the positioning of the applicators inside the 3D imaging. But 3D library of the applicator is not existing feature in the treatment planning software. So it didn't, for us, we actually tried to develop those. Let's say like this, we have a patient that requires applicator, let's say 10 by 10. In the same way as you would in a Microsoft Word generate a table, you would type, I want my table with the 10 rows and the 20 columns. Similar here in our software, we type the size of the applicator. This applicator has in our software has a provision that can bend, but the distance between the adjacent valve position would stay the same. So it can bend, it can deform, but cannot extend. And therefore, all what is necessary to do is to take the 3D applicator and conform it, put it around the target. Once when we when we virtually place the applicator to match the position of the applicator on the CT images, we know the geometry, we know where the valve positions are, and we are coming to the same problem. Can we define a plane or 100% isodose line as previously explained? Let us talk a little bit about 3D printing and the 3D printing role in HDR brachytherapy. So there are a lot of at least abstract at a major meeting where people reported printing of a 3D applicators. I personally do not believe in a printing of a 3D applicators in a skin brachytherapy, or at least in a complex skin brachytherapy, because in order to put those 3D printed applicator, rigorous QA is supposed to be done. So what is the benefit aside from the idea that you were able to print the applicator? We proposed, and that proposal was published in the Medical Physics, I think last year, to 3D print the holder for the applicator. What are we trying to do there? Why holder? Also, we reported that if we do not put for a skin applicators or for a surface brachytherapy, deliver doses up to 6% colder because of lack of backscattering. So basically, we can print out the holder of the applicator where the applicator should be placed in order to provide for a backscatter and to deliver accurate doses calculated in the treatment planning system. Second thing, if we print out the holder from an applicator using images, using information from a CD images, we know geometry. When we know the geometry, we know position of the dwell points, we know position of the catheters. When we know position of the catheters, we calculate the dwell times that will correspond to 100% of isodose line delivered 3 millimeter under the skin. And these are some 3D printout that we generated, and this is actually how it should be. So with this, we are actually printing out the treatment plan. We are solving two things. First, we will deliver accurate dose as calculated in the treatment planning system, and we do not use standard treatment planning system at all because the holder contains sufficient information about geometry, and corresponding file contains positions of the dwell points and associated dwell times. And that's pretty much it. So conventional treatment planning here is non-existent, absolutely. So we say that we do not print out the applicator or not even a holder of the applicator. We print out the treatment plan. That's the additional approach how the treatment planning can be automated. We actually did several clinical cases, and our therapists, including physicians, like it a lot because this approach improves immobilization, and no one should worry if applicator will fit well and snugly to the target, because that is happening all the time because of the holder that as previously stated, contains a treatment plan, and standard treatment plan is not required in this case. Actually, we play a little bit with lesions on a patient's head and scalp, and we realize that the treatment plans or the dosimetry is superior with respect to the standard or conventional way of treatment planning. Now I will talk about the role of MRI imaging. Usually when people talk about HDR brachytherapy, CT is a standard imaging technique. Some people utilize ultrasound images to assess the depth of the lesion. But the question is 3 millimeter optimal prescription depth? Different patient has a different skin depth. And sometimes we might overdosing or underdosing when because we cannot see the imaging, we cannot see underlying layers of a skin with the CT only. So there is a potential to generate something that we call individualized prescription, where the prescription is not going to be 3 millimeters for each patient. A second thing that we want to assess, for instance, when Dr. Devlin will talk about that, when we see recurrences for a patient diagnosed with angiosarcoma that we treat using a 5 centimeter margin around the scar, we see recurrences at 5.2, 5.3 millimeters. So the question is, what are the treatment margins? So we think that with MRI, or MRI can have strong potential to resolve those issues. Can we go with the individualized treatment depth, and can we extend or even shrink our margin? And that's actually an ongoing study. Recently, the feasibility of MRI only treatment planning, where the CT will be completely eliminated from the process, is reported in the medical physics. So first the task was, can we actually define or develop a sequence capable of seeing the catheters on MRI? That's one part. And the second part, can we define a proper parameter or an MRI sequence that is capable of seeing underlying layers of skin. So these are some results, and these are some results on a patient diagnosed with a CTCL on an arm, and we actually wanted to see in this part, can we do treatment plan based on MRI only images, including a first part, can we identify the catheter successfully? So I'll show you the similar video, but done on the MRI images. So we adjusted or we further develop our algorithm for automatic catheter reconstruction, and we use it on MRI images of a patient with a Freiburg flap applicator placed on the skin. The story is the same. No need in this approach to go part by part or catheter by catheter. It is only necessary to give guiding points or anchor points, and the software should do everything else automatically. So in this approach, we again did 3 slices, and people who are dealing with HDR brachytherapy know that whole this process takes several hours to digitize the catheters on the patient arm in a scenario like this. So the next step is just to run the algorithm, and voila, we have a reconstructed catheter. So the further story is exactly the same as I previously said. If we know the geometry of the applicator, we can easily calculate the dwell times to have 100% isodose line 8 millimeters equidistantly from a shell where the applicators all dwell points are. And the problem of MRI only treatment planning is actually solved. We are investigating further options, and we are trying to put this in a clinical practice. So a few points from this talk. We think that treatment planning should happen in the background. The treatment planning should not take visible or significant amount of time in the future. We should be able to treat our patient faster, and we should be able to evaluate if our patient can benefit from a different imaging modality that will result in potentially improvement of a patient treatment outcome. So all that would potentially improve hospital resources, and we hope that patient will benefit for these approaches. Thank you very much.
Thank you, Ivan. I think we now have Dr. Su is on. Is that correct?
Yes, I believe he is.
Yes. Hello.
So it now gives me great pleasure to welcome Dr. Su, the chair of radiation oncology at Beth Israel-Lahey, who will be speaking on an even larger scale skin cancer, which will be total skin electron beam therapy.
Thank you very much for the opportunity to present about total skin electron beam therapy. This is a relatively specialized treatment that we perform at Lahey, and just wanted to see, can you see my slide here?
Yes, if you want to put it presentation mode, then it'll fill the screen.
Great, thank you.
Yeah, perfect, thank you.
So this is a specialized treatment that we perform at Lahey Clinic, and we've had a long history with some of the earliest reported journal articles about total skin electron beam therapy. And currently we're the regional provider for total skin electron beam therapy in New England. The other notable site being at Yale, where Dr. Wilson is also one of the experts in this treatment. So mycosis fungoides Sézary syndrome, this is a particular form of cutaneous T-cell lymphoma. Just as a biological introduction. Cutaneous T-cell lymphomas are a group of extranodal non-Hodgkin's lymphomas, and they come from T lymphocyte cells that home to the skin. And the diagnosis is fairly complex and requires expert clinical pathologic correlations and the use of immunohistochemistry and molecular analyses. While mycosis fungoides is a common type of cutaneous T-cell lymphoma, as a group, these are not very common cancers. The incidence rate has been estimated at somewhere between 5.5 to 6.5 cases per 1 million people in the United States. The patients may present with a history of a diagnosis of eczema that's longstanding, and then as they're diagnosed with cutaneous T-cell lymphoma, they may present with particular skin lesions like patches, plaques, tumors, or in more extensive cases, erythroderma, which is basically involvement of the majority of the patient's skin. This can be very symptomatic with people having intractable itching and open sores and cosmetically disfiguring lesions. And a common cause of death is sepsis from infection, usually from Pseudomonas or Staphylococcus infections, which can be quite difficult to treat. So the differentiation between mycosis fungoides and Sézary syndrome is based off of the degree of peripheral blood involvement. So in mycosis fungoides, it's more skin level involvement, whereas Sézary syndrome does involve the blood space as well. And as people get more advanced in their clinical stage, they have shortened survival. So while the T cells themselves are very responsive to treatment, and they can people can have remissions or significant responses, cure is hard to achieve. And treatment is considered palliative in most cases, with the exception being potentially stem cell transplantation. So these are some pictures that kind of show you some of the manifestations of cutaneous T-cell lymphoma. On the upper left, this is a patient with patch disease. So patch disease being flat, but you can see the areas of discoloration, which denote the areas of skin involvement. As the lesions become thicker, you may get thin plaques. These may be a couple millimeters in thickness. As you progress on to tumor stage, which is on the upper right-hand side, you get much thicker tumors that can centrally ulcerate and become necrotic. And these patients especially are now more prone to getting skin infections, as you can see with ulcerations. And in the bottom right is a picture of a person with erythroderma. So on the kind of in the middle portion, this is when he is symptomatic and presenting with full erythroderma. You can see the majority of the skin surface is involved with this red coloration. And unfortunately, this patient had responded well to therapy, and you can see the clearance of that red color from the skin surface. So there are many options for treatment of mycosis fungoides or Sézary syndrome. Often they start off with topical corticosteroids and may then move on to nitrogen mustard or other skin-directed therapies. UV therapies are also quite effective. So Sorolin and UVA or narrowband UVB can be utilized. In fact, some patients during the summertime, they just lay out and they sunbathe and get some natural UV light, and that can actually have some effect on their disease as well. We will be talking, of course, about total skin electron beam therapy, and also focal radiation, either with electron beam therapy or with photons, can be used to treat palliatively. There are also some systemic treatments like interferon therapy, interleukin therapies, pixarotene, romidepsin, et cetera. And then finally, allogeneic stem cell transplantation is thought to potentially be curative in a subset of patients who are able to go on to transplant. And here are the overall response rates of these therapies. So the response rates initially can be fairly high, somewhere between 50 to 75%, maybe up to 90% for patients. Unfortunately, they are not necessarily cures, but you may get some durable response for some period of time. This is for the skin-directed therapies on top, and then for systemic therapies, you also see kind of response rates that are overall somewhere in the 40 to 60% range. So for local radiation therapy, these are the ILROG, or International Lymphoma Radiation Oncology Group guidelines for local radiation treatment. This is the use of either on-phos electrons or sometimes with external beam megavoltage photons. So they are effective for a limited number of lesions. The treatment can be with low dose, although if you go to ultra low doses of 4 gray and 2 fractions, the overall response rate is less than 30%. So generally we go to a dose that's a bit higher. So when you get to about 8 gray in 2 fractions, generally the complete response rates can be over 90% in the lesions that are treated. These low doses do allow for retreatment. So if you're treating with 8 to 12 gray for symptom management and for control of lesions, you can, of course, retreat if it grows back. There are some thicker tumors, so tumor stage disease, or in cases of transformation of the disease to a higher grade form called large cell transformation, it may require higher doses for any durable response. So we look at various factors when we think about the fractionation. So certainly the normal tissues, the radiated volume, how the skin is looking, whether they've received any prior radiation, and whether we are considering total skin electron beam therapy. So as we talk about the doses, usually local recurrence is unusual above 24 gray. And because patients respond so well to low doses, the ILROG had recommended a dose range of about 20 to 24 gray for local radiation. And this is fairly consistent with the NCCN guidelines, where they've again recommended a dose range of 8 to 12 gray just for symptomatic management of various plaques or tumors. If it's one lesion and you wanted to get better control, 24 to 30 gray would be sufficient. You would generally build in a margin of 1 to 1.5 cm to account for any microscopic disease beyond the gross disease. And treatment with 6 to 9 MeV electrons with bolus should be adequate in terms of the depth of treatment. Some facilities that have kV energies could consider using 100 kV or so energies for this treatment. When we look at total skin electron beam therapy, the recommendations overall is a dose range of 12 to 36 gray, generally 4 to 6 gray per week. The higher dose range, the 36 gray, has been shown to perhaps have a better response rate. But again, these are considered palliative treatments, and the patients are generally going to recur. So, you know, with the low dose range, somewhere around 12 gray total skin, you can retreat. And so that's one of the advantages. And also there may be fewer short-term complications. So patients have less xerosis or skin desquamation or those types of symptoms. Shadowed areas, which depending on the setup for the total skin electron beam, generally the patients are standing, and so shadowed areas could be areas of the scalp, the soles, the perineum, or if they have significant panniculus, the areas under the panniculus, or the skin in the inframammary fold under the breasts. So those may need to be supplemented with additional electron fields. And individual tumors need to have some boost if they have any particular thickness. So generally a 4 to 12 gray additional boost with electron beam therapy generally would do the trick. So this is the Stanford 6-field technique. These are the various positions that the patient would take in order to have the entire skin surface irradiated over the course of the treatment. So in terms of the efficacy, we're very interested in low-dose total skin electron beam therapy for the advantages that I had talked about before, one being lower side effects and the other being the ability to retreat multiple times if necessary. And you know, patients get the same benefit, I think, from the low-dose technique as opposed to going to the higher 36 gray level. And there are a couple clinical trials that have described the low-dose technique. One of the earlier ones was a trial out of Denmark, where they used a dose of 10 gray in 10 fractions. And they enrolled 21 patients. They treated with 10 gray in 10 fractions with a modification of the six position Stanford technique. Shielded areas were boosted as necessary, so 2 gray times 4 for the electron boosts. And for thicker tumors, they also treated with 15 gray in 5 fractions before the total skin. The advantage of treating before the total skin is that you may then get sufficient shrinkage of the tumor before you start the total skin regimen so that the TSCBT can penetrate down to the base of the tumor. So what they saw was that they saw an overall response rate that was quite good, 95%, with complete responses accounting for about 30% and very good partial response in about 30% of patients. They saw a median duration of about 5.8 months for overall response. And that was certainly longer in people who had complete cutaneous responses, so up to 9 months for people who showed a complete response to therapy. And there was no difference in progression-free survival in patients with the lower T2 versus the higher T3 or T4 disease. If you look at the freedom from progression curves, you can see that, you know, about half of people had no progression at about 6 months or so of after treatment. There was also a report from 3 combined phase 2 clinical trials where they had 33 patients total, and they had been treated to a dose of 12 gray in 12 fractions. And with this low dose technique, they saw response rates that exceeded 88%. Median time to response was about 7.6 weeks, and the median duration of clinical benefit was 70 weeks. So longer than a year. Toxicities were mild, and they showed significant improvement for the patient when they used a standardized tool of modified severity weighted assessment tool. And you can see here in some of the pictures how significant the responses can be, where you have basically complete response of these lesions throughout the body. So again, the median time to progression was beyond a year. So they had very good results that lasted for about a year and a half. So for the Lahey technique, we use basically 8 fields for our setup. We have the machine gantry head at 2 angles, 64.5 degrees and 113 degrees. And with that, we're able to treat with a very diffuse electron beam treatment, and we avoid some of the inhomogeneities that would be introduced if we had the central axis of the beam going towards the patient, going through the patient. The patient is treated on a rotating platform. So on the odd days, we may treat with angles of 70 degree and 150 degrees, with the patient's body going towards the beam, as well as patient's back going towards the beam. And so this gives a very nice coverage of the total skin surface. Then on the even days, we would change the angles. So the patient would be set up at the 30 degree and 110 degree angle on the platform to allow for those, basically a different incident angle of the electron beam. And again, we're treating with the same 113 and 64.5 degree gantry. And these are the PA angles, 30 and 110. So with this technique, over a cycle of 2 days, we're able to give a very uniform dose to the total skin. And we would then, of course, patch on any boost electron treatments that are necessary to treat the soles and to treat the perineum. Occasionally treating the scalp, although if the patient is not particularly tall, the scalp gets a fairly uniform dose that's pretty close to the full dose. This is the percent depth dose curve for our setup, and we prescribe to a depth of 4 millimeters. So that's basically at the 0.91, 0.908% depth dose. And we do measure out the patient's separation, the anterior posterior separation. And we apply a correction factor to the MUs to account for differences in patient separation. As separation goes up, the separation factor goes up. And this is a fairly linear factor. So when we're calculating the MUs for the total skin electron beam treatments, these are the formulas that we are using. So there's an output factor of 0.1556. Then we have the separation factor. Separation factor is based, of course, on that chart that I had shown you. So for this particular patient who had a 28 cm separation, the separation factor was 1.013. And then our PDD is taken at 4 millimeters. So with that, we get our MUs for day 1 and MUs for day 2. When the platform is at the more oblique angles of 30 or 150 degrees, we apply an additional correction factor of 1.06. So this is another picture of just the effectiveness of 12 gray total skin electron beam therapy. So this is a patient who came in with very significant skin disease throughout his body. It's not amenable to focal electron therapies and really requires a total skin electron beam approach. He was very symptomatic with significant itching all over his body from these lesions. So this is pre-total skin electron beam therapy. Then at 1 month, he had very good response of his disease, almost complete response. And then 9 months later, you can see his skin is completely pristine. And he enjoyed quite a long period of time before he had any type of progression of disease. So I'll stop there and of course, open for any questions. Thank you.
Thank you, Dr. Su. I think due to the format of this meeting, we're holding our questions until the end. So we're going to now transition to Dr. Devlin, who will take us back to the middle of the road between the very small and the very large, and talk about some more with surface brachytherapy.
So I'm just getting slides up here, and I'll be rolling in just a minute. I just want to say and take the opportunity to thank Dr. Sue publicly for being such a phenomenal collaborator with the Dana-Farber Cutaneous Oncology Program. He is unfailingly gracious in every aspect of the work we do together, and very supportive of the patients. And we just completely love working with him. Okay, let's see if this now works. Here we go. Let's try this again. Can you see these slides?
Yes, we can. Thank you.
Okay, great. So I'm going to just say that folks know me. I'm just going to talk about two parts of this talk simply. That the first part, I'm going to talk about the ASTRO consensus guidelines for what is the reason, what is the level of data behind using brachytherapy or using radiation therapy in the first place for skin cancers as an equal therapy to the various surgical therapies based on evidence. And I'll just sort of go forward through this. My disclosure is they give us a little money for writing textbooks, and both Rob Cormack and these other wonderful people, former fellows, who have absolutely contributed to this. Just to remember, for brachytherapy, it's for complicated targets. Brachytherapy for deep targets is our GYN and our prostate work, which we're not talking about today, but the superficial targets can include obviously skin and other structures, very superficial and quite difficult to manage with external beam therapies, howsoever good. And only to just make the point that the scope of brachytherapy as defined in this book includes obviously the gynecologic and genitourinary, but also has evidence basis in thoracic, gastrointestinal, CNS, head and neck sarcoma, breast, peds, skin, and vascular. And so that we have a robust subspecialty within radiation oncology with much evidence basis, and important to bring before the physicists at the time of their educational meeting. And I would like to just say, before saying anything else, that the physicians in radiation oncology completely value and completely are thrilled by your presence as scientists and clinicians with us. There is never a centigrade given without you. There is never a centigrade given unsafely because of you. And so the physicians humbly thank you and should continue to thank you for the fabulous, fabulous contribution day in and day out in the trenches that you give, so we can together take care of the suffering humanity. And thank you from all of us to all of you. So let's quickly pop through the ASTRO definition on postoperative therapies. We published this in PPO in 2019, at the end of the year after ASTRO, so it's not that old. And just to say, this is a Delphi process that involved the AAD, the American Academy of Dermatology, the dermatopathologists, the oncologic surgeons, the medical oncologists, the radiation oncologists, and it was really, and patient representatives as well. So really, really broad representation according to what is the most rigorous thing to be doing. I've just summarized this. I don't want to put you all to sleep with the boilerplate of it, but I just want to sort of show you this. Basically, our overview says that we're going to talk about definitive radiation therapy as an alternative for basal and squamous cancer. We'll talk about postoperative radiation therapy indication. We'll talk about the guidelines for lymph node and regional radiation, various talks about issues with regard to dose and techniques, and the role of adjuvants or chemotherapy biologics, and so forth. A very comprehensive document. We wanted to assess the arguments, the quality of evidence. We want to get clear recommendations for care. We want to look towards what we need to study next, and really important, and in my mind, what changes the mind and heart for us to broaden the scope of the things we can do for skin cancers, rather than build walls between the various specialties. And by the way, what and how do we prepare radiation oncology and medical physics to be a place that can do these therapies? And that's just remember that skin cancer is the most common cancer with the least amount of attention paid to it by radiation oncology. And so there really is a need to continue to advocate for the broadening of the training in superficial cancers. Okay, so basically we're just saying that radiation therapy is an effective therapy with durable control and an attractive alternative to surgery. This is a frontier issue for us that when, you know, as you saw in the first beautiful talk, the more science goes into Mohs surgery, obviously the question is what's the role? And the doctor very, very graciously talked about the role possibly of using these optical coherence tomography for brachytherapy clinical target characterization. I certainly am going to follow up with them and our Mohs surgeons myself on that issue. So we have some really good data, which I'm not going to focus on because of time, but there are randomized data which show in that data from 1997 that surgery had slightly higher control, but the 4-year control was 92% for radiation oncology. And please note that neither the surgery nor the radiation therapy were modern. So that's the data coming from beginning in 1982, not really brilliant data, but just to say we have all kind of room to study more. A different meta-analysis of 21 studies showed the local recurrence after radiation to be 2% and at 5 years 14% with excellent cosmesis. And then there's a host of other single studies that we're not going to focus on, but with low recurrence. So the argument is that definitive radiation is a preferred curative therapy where adequate surgery can't support the cosmetic cosmesis and function and in anatomically sensitive areas. And we now have many techniques to further cosmesis and function, and we can prevent poor cosmetic outcomes and poor functional outcomes. And we're going to give you some examples of some of those. Squamous cell does not do as well as basal cell. Okay, so things about dose escalation was okay for basals, but not for squames. And of course, that when you get to high risk stage, we need to do a multidisciplinary approach. That's pretty straightforward. There are some worries to consider about the acute risks of doing radiation therapy, specifically dermatitis, alopecia, and the later risks of telangiectasia, alopecia, and the rare radiation-associated malignancy. And in that conversation with the optical coherence tomography, what a superb presentation to look at the late effect and the late transformation and perifollicular fibrosis seen on optical coherence. I thought that was very, very important for us to engage proactively with that. And by the way, Dr. Barker, who was mentioned in that talk, is a dear, dear colleague and collaborator with us and is a co-author on the ASTRO guidelines, just to let you know we're all working together. So again, for postoperative radiation therapy, these are things that doctor will closer positive margins for various high-risk features, which happen to be big tumors, deep tumors, recurrent tumors, lots of perineural invasion, or which is microscopic, or any amount of gross nerve or bone invasion. Advanced stage disease should have multimodality therapy. And so there are no randomized controlled trials at that level, but high-risk features are identified across pretty much every paper. Okay, yes, it's not evenly presented as basal and squamous, so nothing applies to everything. And there are some areas that are possibly extra risk for higher mortality based on immunocompromise. We see that in the renal cell. Also, the kidney transplant people on immunosuppression, when they get 100 or 200 of these squames or basals on them, and they get nodal disease and they die from the disease. So that's a big, big issue for us to be aware of. So I think that everybody would agree that common early stage skin cancers undergo Mohs surgery with a single fuse and a primary closure. In this situation, there's no deficit to functional cosmesis disfigurement, and there's minimum psychological and physical pain. But if there are multi-stage procedures requiring delayed primary closure, skin graft advancement, rotational, or free flap, or as I saw the other day, a cartilage transplant, there is a significant risk to function, cosmesis, and disfigurement. There is significant psychological, physical pain, and a lot of these, they're going to have post-operative therapy anyway. So the argument would be, in the first case, to do definitive radiation therapy as a modest proposal, no more. And then to sort of say, where should we go in the future? We should go to prospective multidisciplinary evaluation to work towards new randomizations with modern radiation therapy matched to modern surgery to seek non-inferiority of modern radiation therapy in locally advanced cutaneous malignancies. This is where this specialty should go. And a lot of us are talking around that with our fabulous colleagues in dermatology as a collaborative thing, as you saw in the Sloan Kettering presentation, which is a phenomenal presentation. I'm going to skip over lymph nodes for now because it's not germane to where we're going in this conversation. But we've got, as you know, electron therapy. We've got all kind of photons, which are external beam with superficial IMRT and VMAT. Orthovoltage is in some places. My own practice is pretty much universally high dose rate single plane implants, but understanding we have the ability to do interstitial and superficial, and just a nod to electronic brachytherapy that we have not adopted ourselves, but definitely has a part in the smaller skin cancers. And we've talked about dose before, but definitive dosing, like external beam, it looks like 66 gray or so with reasonable hyperfractionation, 50 to 54 gray, or some ultra hyperfractionation. You see this more in Europe than here at the 5 gray for 8 fractions. That's a little dense for my tastes, but that's what's happening around in Canada as well. So maybe we'll catch up. Okay, we're going to skip the immunotherapies and the chemotherapies just in the interest of time here. And we're going to go to, this is a patient could well have shared with Dr. Su. They're a cutaneous lymphoma. This looks like patch stage disease here on the, looks like the thigh, and here on the ankle and on the foot. And an interesting clinical target for a beam approach with a complicated curvy surface. So we're going to characterize this actually is the leg, not the thigh. So we're going to characterize the gross clinical target volume. The redness that you see is how I'd characterize that. And then adding a physical 2 centimeter peripheral clinical CTV, PTV around that. And then this one is the foot. And I want you to look at this, that is near circumferential to be able to treat. So this is coming around, it's the whole of the sole of the foot and some sparing up top on the dorsal aspect of the foot. And this is the classical Freiberg flap wrapped with an ace bandage. And again, the foot wrapped with and the foot does represent quite big challenges to do definitive beam therapies for. So this is a clever alternative that my group has developed, and we've propagated and taught through the ABS and through Astro, pretty much, and through Jekester also, and through the Australasian brachytherapy group as well. And then the idea you hear, and you saw a beautiful pictures with Ivan, this 100% isodose line being very conformal with a very rapid dose fall off here, so that no risk of getting, no risk of ablating the deep lymphatics and causing an edema to that. This then is another facial situation where the target itself is a very complicated contour, undulating contour with ultra sensitive structure, the eyes, the lens, the cornea, conjunctiva, right underneath that, and figuring out ways to treat one without treating the other. And again, this is just a lovely dose distribution to the anterior face, and again, carried out through the sagittal section as well, to be able to deliver 100% very, very conformally with no toxicity, and the use of some eye shields, which are not shown in treatment planning, to shield the structures of the eye. If the eyelids are involved, there'll be internal eye shields. If the eyelids are not involved, there would be external. And then this is a B-cell cutaneous lymphoma, which is sitting on the vertex of the scalp, and the clinical target is sort of like the shape of a yarmulke or a ball cap. And so what you have here, again, this beautiful dose distribution are clearly along with an ultra rapid fall off across the area. So we're not giving appreciable dose to the brain. Again, this is now the back of his head, the same patient needing the whole scalp done. One can do the whole scalp in one sitting, Sometimes I prefer not to do that. It's just so to make the therapy tolerable to a patient who is treated sitting up, not lying down on the table. Again, beautiful dose distributions. And now this is something that I think brachytherapy has a nice application. This is known as a dumbbell keloid. It's like one of the things you go to the gym and you lift for your weights like this dumbbell. I think that's the name of it. So this keloid, from just a piercing, he just went to get a diamond stud in his ear. A lovely lad and a member of our hospital community, for which he went for an excision. And I unfortunately didn't get the excision, but these were cut out and a tiny little stitch line was placed. And we've made a wraparound applicator with 2 catheters behind and 3 in front, taped to them like that for treatment planning. And I will note that the isodose distribution for a tiny target, and that's the idea. I'm not sure I brought this picture with me, but we've placed lead, a wax-coated lead there, and there. So there's no scatter dose at all. It's just on the area of where the surgeon's injury was to do the surgery. That is the clinical target. And we now are dosing that at 3 fractions of 6 gray for a total of 18 gray, according to a German study. And again, this is another post-operative keloid here. That was excised. I don't have the big picture there. And again, a clinical target of 2 centimeters around the area there to take account of all the injury that was caused at the surgery. And then the dose distribution to be very nice and not affect the oral cavity in the least. If you're on the cheek, by the way, you can put in dental rolls and push the cheek back out away from the teeth and away from that backscatter we get from fillings. And then this is a large surface area. This is the same patient Ivan showed, just a different area of a cutaneous lymphoma, and the use of a large surface area of brachytherapy applicator over the curves. Now, some people, if you were doing this with electrons, it might be as many as 4 electron fields or more electron fields with the inhomogeneities at the match. So one of the solutions to this is to do surface brachytherapy in the following manner. Again, there are flat sections and there are curved sections, but there is a very homogeneous dose across the entire clinical target. And again, this is something that is a very near and dear to my heart. We've been treating penis cancers. This is actually, it happens to be extramammary Paget's disease. The surgeon's answer to this is to remove the penis and the scrotum and the mons area and skin on the thigh and create an absolute disaster of an emasculation, which has a suicide rate attached to it. And so we have been modeling and figuring out ways to give superficial radiation to the external male genitalia while preserving both the physical genitals and preserving the function and controlling the disease. Quite a tall order. We have written about it, and it's an evolving area in which we need a lot of prospective study to go forward. And so the dose distribution is just like this. It's just the skin. There's no cancer in the urethra in this one. So you have down here this 100% isodose line. This is a custom-made applicator where you've basically taken a little bit of a mesh, you've woven in brachytherapy catheters to the mesh, and then you put them sandwiched between a half centimeter bolus, both internally and externally. And then you can see that here. There is the catheter. This is bolus. That is the clinical target. We get a dose distribution and a reliable setup to give a definitive dose. Talking of small subjects, this was a squamous cell carcinoma with a positive margin on the extensor tendon of, it's jumping forward on its own, extensor tendon of the ring finger in a left-handed man. And the surgical answer for that positive margin is called a ray amputation, where you amputate the finger like that. Well, this guy didn't want his finger amputated, nor did I want it to do. So we took this positive margin and again made him this little mesh. You find the mesh at the bottom of the aquaplast box. If you want to know where to find it, you put the tiny prostate needles, so what they are, 5 millimeters apart. You fix it with a little bit of aquaplast like this, and then set it up in a similar way every day. And then the dose distribution couldn't be prettier. Isn't that gorgeous? Come on, give it up for dose distributions. That's the best one of the day. And again, that way the acute reaction is exactly that. And the finger is cured. And this is a 2-year picture of a completely normal, non-swollen, beautiful outcome and no recurrence. Okay, so that's an important thing to be able to do. And again, lastly, the angiosarcoma case, this wonderful patient still alive and kicking some 5-8 years later for a disease that universally is fatal. And so he had an excision. Every excision in angiosarcoma always has a positive margin. And as Yvonne had mentioned, this ability to give at least a 5, you treat as much as you can. Dr. Delaney, the wonderful doc at the Mass General, once said to me, I said, how much is enough and how much is too much? And he said, Philip, put the whole head in the oven, is how he said it, because it's such a devastating disease. Well, we've managed to control this with a good 5 centimeter distribution, fractionation, and again, familiar story of that lovely, lovely dose distribution. So these are something that we want, essentially, I'll just come to that in a minute. We want all of you to be able to do in your center, and we invite you to come and observe with us if you'd like to start a program, and we would be happy to work with you so that this is an available modality within your center. Okay, a nod to Astea, electronic brachytherapy, you saw it a bit earlier. It does have a role in smaller lesions. Bringing that into the centers has been difficult for us. I think there are some around town, and I'm interested to move in that direction, but we haven't done it ourselves yet. Okay, so that's really just to say that we hope to provide an academic environment to invigorate multidisciplinary cutaneous study and practice. I say there's no limit to the expansion of this evidence-based uses of brachytherapy for cutaneous sites. We want to continue to train doctors and physicists together, and we want to educate the entire medical community and the Cancer Center as to the richness of our specialty and its full potential for them and for our common patients. Thank you very much.
Thank you, Dr. Devlin. I think at this point we have a couple minutes remaining to hit some questions. One question that did come in through the chat is for Dr. Su, asking about the challenges of curved surfaces in total skin electron therapy. I guess it comes down to 2 questions. To frame the question would be, what sort of dose inhomogeneities do you see over the distribution of the body? And then are there any particular methods that are used to reduce those?
Yeah, so in terms of I think the original question also included a question about contouring. So for total skin electron beam therapy, we do not do any contouring of the total skin, but we do prescribe to a standard depth of 4 millimeters. And dose inhomogeneities, depending on the curvature, we've seen based off of direct measurements somewhere, in the 15% range, which I think is reasonable for the dose and the application. This is again something that's palliative, and we have direct visualization of the effect of the total skin, so that if a patient comes back for follow-up at a month or so, and there's something that we can visually see that has not responded so well, we always have the option of boosting that with focal electron beam treatment. When we're delivering to shadowed regions, the setup is fairly standard in terms of on-phos electron treatments to the soles and the perineum. We know from prior measurements that those areas can only receive a small fraction of the total skin dose, just because they're orthogonal to the beam, basically. And so we've come up with standard dosing of 12 gray in 6 fractions for the perineal boost and the boost in the soles. And we do kind of a more prolonged fractionation for those regions because they can be fairly sensitive And also there is some overlap between the total skin portion of the treatment and the electron beam portion of the treatment. And so that more gentle fractionation allows for that overlap with no significant clinical side effects.
Thank you. I have a question for Yvonne. We're going into a realm of radiation therapy where we're very much focused on efficiency. And you mentioned the difference between QA for a brachytherapy applicator holder versus a 3D printed custom brachytherapy applicator. Could you delve into that a little bit further, in particular, how it might affect the patient flow through the clinic or the timing of activities relative to the patient in the clinic?
So basically, if you have a holder implemented in a clinic, all you need to do is to make sure that your FibroFlop applicator will fit inside the holder. No additional QAs are required. When you have a newly developed applicator, you want to make sure that each channel is printed out properly so that radioactive source would not stuck inside the catheter. Therefore, you have to go and do something that is similar like IMRT QA. You have to deliver the full treatment prior to real-time delivery, and that actually includes utilization of additional resources, physics, you have to utilize the room, afterloader, etc. So that type of strategy was not acceptable for us because it works on the opposite direction. It increases utilization of the resources versus optimizing utilization of the resources.
Do we have anyone from dermatology on to follow up on the optical coherence talk?
Yes, hi, this is Dr. Cordova. I'm covering Milind, so if you have any questions about it, this is...
I had a rather general question. We were very much focused on these Mohs surgeries, which are relatively small and very detailed optical imaging. Do you see any vision for that going beyond these small tumors to something larger, more along the lines of what you saw with some of Dr. Devlin's case studies?
Well, most of the cases that we use this non-invasive imaging in the Mohs setup is actually less than 8 millimeters. So, this technology, the field of view is very small. The RCM pretty much is the handheld that we use is less than 1 millimeters. So, and the depth actually reached 200 to 150 microns. So it's useful for good assessment and lesion which are maybe less than 8 millimeters for a mosaic with a 1500 vivascope, but also is doable in other larger lesions where we can use a handheld device.
Thank you.
And Rob, I see a couple of hands up.
Yeah, I was going to say, Chris, do you want to jump in with your question?
Yes, I do. I have a 2-year-old that is unhappy with her iPad for a moment here, so pardon me. My question is actually one of the total skin questions for the technique, and I really appreciated how you kind of mimicked a rotational technique using those sort of 8 different gantry angles. And one question I've always had about that is, so when you have the legs, the Stanford technique nicely prevents one leg from shadowing the other leg as the beam comes through. And so with your angles, do you have to worry about the legs or the arms, like the one arm shadowing the other arm, or one leg shadowing the other leg? That was, I think, the cleverness of the Stanford technique, is it avoided shadowing. And maybe your angles also avoid that. So I wanted to hear more about that.
Yes, actually, we had picked the angles in order to minimize that shadowing technique, that shadowing issue. So you can kind of see. Well, when I had the slides up, that we had angles that were fairly shallow and angles that were fairly deep, and we were alternating these angles from day to day. So we found that it's given a fairly uniform dose actually to the legs and the arms.
Thank you.
Thank you.
And Dr. Devlin, did you have something to ask or add on?
Yeah, just to respond to Dr. Cordova, truly fabulous work and collaboration together between radiation oncology, the image physicists, and the surgeons there, showing multidisciplinary care, pushing out research into the frontiers. That's absolutely fabulous. Certainly, we up in Boston would benefit from tagging along, learning, and we'll track with you and see if there's things that we can jump on and do some of that with our 3 Mohs surgeons that we have in-house. And thank you for being with us.
Oh no, that's a pleasure. Actually, we have the honor to collaborate with the physicists and from Northeastern and developing this non-invasive prototype device for the last 4 or 5 years, which is put in practice for triage. And there is a combined device with Milind. Rajadhyaksha presented early is combining confocal microscopy and optical coherence tomography for a good assessment only of the lateral margins, also for the deep margins. So pretty much we can kind of subtype in the clinical setup. So we're talking about all biopsy lesions that comes to the Mohs clinic. This is not really a new lesion, which is, we don't know the histology. All these lesions, early superficial basal cells or early basal cells and being diagnosed, we just assuring that the right management using this non-invasive imaging.
Thank you.
Thank you. I'd just like to step in now. I think we have to bring this has been a great conversation. I think we have to bring it to a close, though. I'd like to thank all the speakers for some very interesting presentations and the discussion that follows. And I think now we will bring this panel discussion to a close. Thank you.
Thanks. Thank you for having us.